Welcome to the deep dive. We've got a really interesting and I think for many a very relevant source today. It's Back to Great Sex, Overcome ED, and Reclaim Lost Intimacy.
That's right, by Dr. Ridwan Shabsai, and it has a foreword by Nobel laureate Dr. Louis Ignarro.
So the goal here, what you're looking for, is really a clear, empowering take on erectile dysfunction, or ED, based on what these experts are saying.
Exactly. The mission for this deep dive isn't just listing facts from the book. It's about giving you, the listener, a clear, concise, and genuinely empowering view of ED. You know, what it is, the causes.
And crucially, what can actually be done about it.
Precisely. We want to sort of cut through the stigma, the misinformation, and get right to the core of it.
And it's a surprisingly big issue, isn't it?
Yeah.
Dr. Ignarro mentions, I think right at the start, something like 30 million American men deal with ED.
It's a huge number, almost like a silent epidemic, as you said.
Yeah.
And what's really striking, despite how common it is and that it's often very treatable, over 75% of these men, they don't actually seek medical help.
Wow. That's a lot of people potentially missing out.
It really is. Missing out on solutions, on a better quality of life.
Which brings us, I guess, right to the main message of that first chapter Dr. Shabsai lays out. It's basically, stop the excuses, start talking.
Yes. Talk to your partner. And, really importantly, talk to your doctor.
Okay, let's unpack that. What exactly is erectile dysfunction? What's the official definition?
Well, the book uses a clear medical one from the first international consultation on ED. It's the consistent or recurrent inability.
Consistent or recurrent, okay.
Inability to attain an odor and maintain an erection sufficient for satisfactory sexual performance. The key words really are consistent and recurrent.
Right, so it's not about the occasional difficulty.
Exactly. I think that's where a lot of worry comes from unnecessarily. Dr. Shabsai is really clear here. Those occasional times may be super stressed, tired, a bit sick, too much alcohol.
Yeah, things that happen to everyone sometimes.
Right. Those isolated incidents aren't necessarily ED. The World Health Organization even suggests difficulties need to be present for at least 3 months usually before you really need to seek professional help.
Okay, so it's about a pattern, not just a one-off. That's important context.
Definitely.
But if it is a pattern, why the avoidance? Why don't more men seek help? The book gets into those common excuses, doesn't it?
It does, and Dr. Shabsai really tackles them head on, because these excuses, they really block people from getting help. Like, oh, it'll just go away.
Wishful thinking, maybe.
Pretty much.
Yeah.
But the book points out ED often gets worse in silence, ignoring it. It's not likely to magically disappear. It usually becomes more ingrained, affects relationships, affects your well-being.
Another one, it'll get better when work stress eases up. That feels pretty universal.
Oh, absolutely. And stress can play a role, no doubt. But the key point the book makes is, if the stress does ease up and the ED is still there,
then it's time to get it checked.
Exactly. Don't just assume stress is the only cause and delay things. It might be masking something physical or just making it worse.
Okay. What about, it must be my blood pressure meds? That sounds plausible.
It does. And some meds can impact function. Plus, high blood pressure itself is a risk factor. But the advice is clear. Don't just accept it.
Talk to the doctor.
Yes. Talk to the doctor. Maybe they can adjust the meds or look for other factors. And crucially, Dr. Shabsai warns, never stop prescribed meds on your own.
Right. That could be dangerous.
Very.
And there's the delicate one. It's my partner's fault.
Yeah, that's complex, emotionally charged. And while, sure, a partner's changes might affect the dynamic, blaming them for the ED itself, that avoids the real issue.
It shuts down communication.
Totally. Communication is vital, and recognizing ED is primarily about the man's physiological response. Blame just builds walls.
And the last big one, just happens with age. Gotta live with it.
Well, yes, the prevalence does increase with age, but the book strongly argues age alone isn't a reason to give up.
So it's not inevitable.
Not at all. If there's still desire, reasonable health. Regaining function is often very possible even later in life. Dismissing it because of age means missing out.
So it really sounds like step one is just acknowledging it.
Yeah.
Opening up those lines of communication. Partner, doctor.
That's the foundation.
The book also gives this really interesting history of how we've understood ED over time. It's changed quite a bit, hasn't it?
It really has. It shows how far medicine has come. Early 20th century, it was mostly about hormones.
Thinking it was just hormonal imbalance?
Primarily, yes. Then mid-century, the focus shifted dramatically.
See, the psychological.
Exactly. The prevailing idea became that ED was mainly mental or emotional, anxiety, conflicts, that sort of thing.
And then the 80s brought another shift. With more science.
Yes, the 80s were key.
Yeah.
Big move towards recognizing organic physical causes, driven by a better understanding of vascular stuff, blood vessels,
The plumbing.
the plumbing, exactly, and the anatomy. A huge milestone was 1982, the first report that injecting papain directly could cause an erection.
Wow. Okay. That must have really changed things.
It was a game changer for understanding the physical mechanics.
And the 90s built on that momentum.
Definitely. We got better classifications, organic, psychological, or often a mix, plus big studies.
Like the Massachusetts male aging study.
Right, started in 87, gave us real data on how common it was. Then the National Health and Social Life Survey in 92. And importantly, also in 92, the NIH set a formal definition.
Making it a recognized medical condition.
Solidifying it, yeah.
And then, 1998, the arrival of Viagra.
Ah, yes. Viagra, sildenafil. A watershed moment, no question. As Dr. Ignaro notes in the foreword, it suddenly brought this taboo subject right out into the open.
Made it okay to talk about.
Hugely impactful. And it spurred rapid development. Late 90s, early 2000s saw a surge in new treatments. Dr. Shopsai even mentions drugs that were in trials back then, like Cialis, Vardenafil, Upramay.
It's amazing how one drug could change the conversation so much.
It really did. And the 2000s also brought more focus on male aging, andropause, male menopause, though those terms are debated. And the book even projected staggering numbers.
What were they predicting?
Around 322 million men worldwide with ED by 2025 really puts the scale into perspective.
It truly does. So our understanding went from hormones to psychology to physical causes, and now
Yeah,
it's more integrated.
exactly. Hormones, mind, body, it's all connected. Which brings us nicely to the actual physiology, the plumbing, as the book calls it.
Okay, let's talk plumbing.
Okay.
Walk me through how an erection is supposed to work.
Okay, simplified, right? It starts with signals, brain signals.
Got it. Brain first.
Those travel down the spinal cord, out through peripheral nerves to the corpora cavernosa.
Those are the spongy tissues inside the penis.
That's them, designed to fill with blood.
So a nerve signal arrives, then what?
Those nerves release a key chemical messenger, nitric oxide, NO.
Nitric oxide. That's Dr. Ignaro's Nobel work, isn't it?
Exactly. His work was about NO's role in vasodilation, widening blood vessels everywhere, including the penis.
So NO triggers the physical changes.
It kicks off a chain reaction, leads to another chemical, CGMP, cyclic guanosine monophosphate.
And CGMP,
Yeah.
okay, what does that do?
That's the chemical that makes the smooth muscle tissue in the penis relax.
And when those muscles relax.
That's the magic. Arteries expand, dilate, much more blood flows into the corpora cavernosa.
More blood in.
And at the same time, the veins that normally drain blood away get compressed. They constrict.
So blood gets trapped.
Precisely. Increased inflow, reduced outflow. That causes the swelling, engorgement, rigidity. The erection. It's a clever system.
It really is.
Mhm.
Brain, nerves, NO,
Yeah.
CGMP, muscles relax, arteries open, veins close. Makes sense. Now, the book mentions an enzyme, PDE5. That's important for how some meds work.
Absolutely crucial. PDE5 is essentially the off switch. Its job is to break down CGMP.
So when the erection isn't needed anymore,
Right. Stimulation stops, body signals it's over, PDE5 breaks down the CGMP, muscles contract, blood flows out, penis returns to flaccid state.
and medications like Viagra.
They inhibit PDE5, block the off switch. So with stimulation, CGMP levels stay higher for longer, making it easier to get and keep the erection.
Okay, so the plumbing is this complex dance. Brain, nerves, chemicals, blood flow, PDE5 regulating it. With all that complexity, it makes sense things can go wrong.
And unfortunately, yes, lots of potential points of failure.
The book breaks down the causes, right? Physical versus psychological.
It does.
Yeah.
Physical or organic causes and psychological ones. But importantly, it stresses that it's very often a mix.
How so?
Well, maybe it starts physical, but then the worry, the anxiety about it, that adds a psychological layer, makes it worse, creates a cycle.
Well, let's start with the physical causes. The book lists quite a few diseases.
Yes, several common conditions are big players. Diabetes is major nerve damage, blood vessel damage, both critical for erection.
Heart disease, too.
Definitely. Vascular issues, high blood pressure, high cholesterol that lead to arteriosclerosis, hardening of arteries, restricts blood flow.
Who else?
Things like multiple sclerosis, Parkinson's, Peyronie's disease, that's curvature of the penis kidney disease, stroke. They can all contribute sometimes.
That's a lot of potential health links.
Yeah,
What about physical trauma, surgeries, injuries?
absolutely. Major pelvic surgery for prostate, bladder, rectal cancer can damage nerves or blood vessels. Spinal cord injuries, pelvic fractures, even radiation therapy to the area.
Unintended consequences sometimes.
Exactly.
And lifestyle.
Yeah.
The things we maybe have more control over.
Huge factor. Smoking is a big one. Damages blood vessels
It
everywhere.
restricts flow again.
Yep. Excessive alcohol, nerve damage, hormonal effects. Illegal drugs, nervous system, blood vessels. And just being sedentary, lack of exercise. Poor cardiovascular health affects everything.
The book even cited the Sexual Medicine Society on smoking, right?
It did, clearly linking smoking as a risk factor.
Okay, that covers a lot on the physical side. What about the psychological causes?
Very common. Either as the main cause or a reaction to physical issues. Stress is huge: work, home, life. Anxiety, especially performance anxiety.
Worrying about whether it will happen.
Exactly. Which can become a self-fulfilling prophecy. Depression is a major factor too. Relationship problems, conflict, poor communication, low self-esteem. Even anger, suppressed or expressed. The mind-body link is powerful here.
The book mentioned a specific term, acquired psychogenic erectile dysfunction.
Right. That just means a guy used to have normal function, but now has problems purely due to psychological reasons that develop later.
So it's not always physical from the start.
Correct. It can emerge due to life events, mental health changes. And even when it starts physical, Dr. Shabsai notes there's almost always a psychological reaction, frustration, anxiety that piles on top.
It really highlights that connection, mind and body. So with all these potential causes, physical, psychological, mixed, seeking professional help seems absolutely vital.
It's the essential next step.
The book really pushes talking to your doctor.
Yeah.
That's the main takeaway there.
The number one message. ED is treatable. Highly treatable. So overcome the embarrassment, the awkwardness, be open with your doctor.
It's the first step to getting better.
Absolutely. The first most critical step towards reclaiming intimacy, well-being. Take charge.
And the book gives practical tips for that doctor visit, making it productive.
Yeah, great advice. Like, read up a bit beforehand. Write down your questions. Be ready with your history, medical, sexual, meds.
Take notes during the visit, too.
Yes, so you remember what was said, the recommendations. Being prepared makes the conversation much better.
Good advice for any doctor's visit, really. What if your regular doctor doesn't seem comfortable or knowledgeable enough?
Good question. The book suggests, if that's the case, don't hesitate. Ask for a referral to a specialist.
A urologist.
A urologist, yes. And ideally, Dr. Shabsai says one who specializes in ED. They'll have the deepest knowledge, the most experience.
So advocate for yourself. Seek specialized care if needed.
Definitely.
Okay, so you make the appointment. What actually happens during the evaluation?
Right.
What should someone expect?
It's usually pretty comprehensive. They start by gathering info. A detailed sexual history, what's happening, when it started, situations. Full medical history, conditions, surgeries, all meds, even over-the-counter stuff.
Psychosocial history, too.
Yes, very important. Overall well-being, stress, relationships, mood issues like depression, anxiety, and then a physical exam.
What does the physical exam involve for ED?
Usually a general checkup plus a specific look at the genital area, penis, testicles, prostate. They might check sensation in the penis, nerve function. Sometimes a bulbocavernosus reflex check.
Sounds straightforward.
It generally is. Routine, not usually uncomfortable.
And lab tests, blood work.
Almost always. Blood and urine tests. Checking testosterone, other hormones, lipid levels like cholesterol. Looking for clues about underlying physical issues.
Now, sometimes the doctor might need more info, right? The book mentions specialized tests.
Yes, those come into play if the initial evaluation isn't clear or if they need specifics to guide treatment. Dr. Shabsai stresses there's no single perfect test. Each has its place.
What are some examples of those specialized tests?
Okay, there's nocturnal penile tumescence testing, often with a device called Regiscan. You wear it overnight.
To see if erections happen during sleep.
Exactly. Helps distinguish physical from psychological causes sometimes. Then there's duplex Doppler ultrasound. Uses sound waves to measure blood flow in the penis arteries, usually after inducing an erection with medication.
Checking the plumbing directly.
Pretty much. More invasive tests exist, like cavernosometry and cavernosography, to check for venous leaks, blood draining too fast. Penile arteriography looks for artery blockages. And various neurologic tests check nerve function in detail.
Sounds like a thorough workup if needed.
It can be, tailored to the individual.
So once they have a better idea of the cause, what's the general treatment approach? The book mentioned a stepwise process.
Right. Stepwise means starting with the least invasive options first, then moving up if needed, finding the simplest, most effective solution for that person.
And treatments fall into categories: first, second, third line.
Broadly, yes. First line is usually lifestyle changes and oral meds. Second line might be vacuum devices, intraurethral therapy, injections. Third line is more invasive implants, sometimes specific surgery.
And counseling could fit in anywhere.
Absolutely. Psychological counseling, sex therapy, beneficial at any stage, since emotional factors are almost always involved.
Okay, let's dig into first line. Lifestyle changes seem like a logical starting point for lots of things.
They really are fundamental. The book emphasizes addressing those modifiable risks. Stop smoking, lose weight if needed, exercise regularly, manage diabetes, blood pressure, cut back on excess alcohol, avoid illegal drugs, address depression, just general good health.
Makes sense. Better overall health often means better vascular and nerve health.
Exactly. These changes alone can sometimes improve things or at least make other treatments work better.
And then the big one, oral medications. The PDE5 inhibitors, like Viagra. How do they work again?
Right. Viagra, Cialis, Vardenafil, they're PDE5 inhibitors. They block that enzyme, PDE5, that breaks down CGMP.
Keeping the on signal stronger.
Essentially, yes. With sexual stimulation, CGMP levels stay higher, making it easier to get and keep an erection. But, crucially, stimulation is still needed. They don't work automatically.
How effective are they generally?
The book says around 70% effective for men with ED, which is pretty good.
What about side effects?
Common ones are usually mild, temporary, headache, facial flushing, upset stomach, maybe nasal congestion, some temporary vision changes. Generally, no major long-term issues with proper use.
But there are important precautions, right? Especially with nitrates.
Absolutely critical. Never take PDE5 inhibitors if you use nitrates for heart conditions. The combination can cause a dangerous drop in blood pressure.
Life-threatening.
Potentially, yes.
No.
Also, heavy fatty meals can slow down absorption for some. Take only as prescribed, usually once in 24 hours, and never buy them online or from shady sources.
Counterfeits are risky.
Very risky. Get them from a legitimate pharmacy with a proper prescription.
Now, when this book was written, around 2001, 2002, some newer drugs were coming out. Cialis, Vardenafil.
Yes, Dr. Shops, I mentioned them. Cialis, tadalafil, was noted for its longer duration, potential for more spontaneity. Vardenafil, another effective PDE5 inhibitor.
And Upramay. That worked differently.
Right, Upramay, apomorphine activated erection centers in the brain. Faster onset, may be usable for some nitrate patients, but it had a risk of fainting, so precautions were needed. It's less common now.
Interesting how the options have evolved. What about natural treatments? People are often interested in those.
Dr. Shapsai acknowledges the interest, but urges caution. Generally, there's a lack of strong scientific evidence for most.
So things like yohimbine, ginkgo, L-arginine.
He mentions them. Yohimbine might increase blood flow, needs a prescription. Ginkgo, maybe blood flow. L-arginine, limited success. Ginsenoside, maybe some effect in psychogenic ED. Argin Max, a combo, limited success. But overall, not strong evidence.
And he warns about bogus products.
Strongly. Lots of fraud, misleading claims online and over-the-counter, lack of regulation, unknown ingredients, dosages. Stick with proven, regulated treatments advised by a doctor.
Good advice. Okay, so if first line doesn't work, we move to second line. What's included there?
Second-line options include vacuum constriction devices, intraurethral therapy like MUSE, and injection therapy.
Let's start with vacuum devices. How do they work?
It's mechanical. A plastic cylinder goes over the penis. A pump creates a vacuum, drawing blood in.
Creates the erection that way.
Yes. Then a constriction ring slides onto the base of the penis to trap the blood and maintain the erection after the cylinder is removed. Ring stays on for up to 30 minutes.
Effective, maybe, but any downsides?
Can be effective, yes. Non-surgical. But drawbacks. Some find it cumbersome, interrupts foreplay, can cause pain, numbness, bruising from the ring. Feels less natural for some couples.
Okay, then MUSE, intraurethral therapy. How does that one work?
MUSE involves inserting a tiny medicated pellet of prostaglandin into the urethra opening.
The medication gets absorbed locally.
Right. Relaxes smooth muscles, dilates vessels, helps blood flow for an erection.
How well does it work compared to other things? Side effects?
Generally less effective than injections, the book says. Side effects can include penile pain, sometimes dizziness, and oral sex isn't recommended after use due to partner absorption risks.
Got it. Then there's injection therapy, self-injecting medication.
Yes. Directly into the side of the penis, the corpus cavernosum. Usually alprostadil or sometimes bimix, trimix combinations.
Well, how effective is that?
Very effective generally.
Yeah.
Works quickly, 5-20 minutes. Erection lasts about an hour usually. Directly relaxes muscles, boosts blood flow.
Seems powerful.
Yeah.
Any major risks or considerations?
Well, it involves a needle, which puts some people off initially, can cause mild pain, bruising. The main serious, though rare, risk is priapism.
Prolonged erection.
Exactly. Painful, lasts over 4 hours. That's a medical emergency. Needs immediate attention to prevent damage. Also, usage frequency is usually limited.
Okay, so that covers second line. If those don't work or aren't suitable, we get to third line therapies. Penile implants.
Yes, implants are the main third-line option. More permanent, often a last resort when other things fail. Two main types, malleable and inflatable.
Malleable are always firm.
Kind of. Bendable rods provide permanent firmness. You position them up or down. Inflatable are more complex cylinders in the penis, pump in the scrotum, fluid reservoir in the abdomen.
So inflatable allows for a more natural, flaccid state.
Yes, and you inflate it for intercourse, then deflate. More natural look and feel for many.
What are the pros and cons of implants?
Pro. Highly reliable for erections, high satisfaction rates usually. Inflatable offers spontaneity. Cons, it's irreversible surgery. Risk of infection, complications, maybe some loss of sensitivity. Mechanical issues possible with inflatables over time. Malleable can be harder to conceal. Cost is also a factor.
And vascular surgery, you mentioned that briefly.
Penile revascularization, very specific cases, usually younger men with ED from arterial damage due to trauma, not common for typical ED causes like aging or diabetes.
Okay, so across all these options, the book stresses other important things too, right? Like psychological support, partner involvement.
Hugely important. Dr. Shopsai really emphasizes counseling and sex therapy, helps with anxiety, depression, self-esteem issues that often come with ED.
Improves communication too.
Definitely, between partners, modifies negative behaviors or attitudes, and partner involvement in the whole process. Crucial for understanding, support, success, ED affects the relationship, not just the individual.
Makes total sense.
Mhm.
What about the link between ED and heart disease that came up earlier?
Critical point. Shared risk factors, high blood pressure, cholesterol, diabetes, smoking. So ED can be an early warning sign for heart issues.
So getting checked for ED is also about checking heart health.
Absolutely. Comprehensive evaluation is key. And remember the nitrate warning with PDE5 inhibitors, that dangerous interaction. Also, discussing safety of resuming sex after a heart event with your cardiologist is vital.
Good points. And ED after prostate surgery? A common concern.
Yes, common side effect, especially after radical prostatectomy. Nerve-sparing techniques help, but damage can still happen. Recovery varies.
But treatments are still available.
Yes, definitely. Even if ED persists after surgery, oral meds, injections, vacuum devices, implants options still exist to regain a sex life.
The book also touches on related issues: desire problems, orgasm difficulty, perinees, premature ejaculation. The message there.
Basically, these are also treatable conditions. If you're experiencing them, seek help. There are specific treatments available for each. Don't ignore them.
And finally, privacy. It's a sensitive topic. Any advice from the book?
Acknowledges the sensitivity. Recommends being clear with your doctor's office about preferred communication methods. Ensure confidentiality. Sadly, in some cultures, privacy concerns can be a barrier to seeking needed care.
So choosing a treatment isn't just about physical effectiveness.
Not at all. It's personal. Needs discussion with doctor, partner, weigh simplicity, invasiveness, effectiveness, side effects, cost, and crucially, personal and partner satisfaction.
The book includes a chart to help with that comparison.
Yes, summarizes pros, cons, costs of different options, a useful tool for those discussions.
Well, this has been incredibly thorough, a real deep dive into Back to Great Sex. To wrap it all up, what's the single most important takeaway message for our listeners from Dr. Shapsai's insights?
I think the core message is really clear and hopeful. ED is common. It's treatable, very treatable for most men. And seeking professional help is the absolute crucial first step.
Don't let embarrassment stop you.
Exactly. Don't let embarrassment or shame or misinformation block you from getting help. Talk. Talk to your partner, talk to your doctor. That's the path back to intimacy and well-being. Use this info to feel empowered.
Great summary. And on that note, a final thought for you, our listener. This deep dive shows that tackling ED isn't just about the physical side. It's tied into overall health, relationships, quality of life. So maybe ask yourself, what small step can you take today to prioritize your sexual health and well-being?
For more info, look for qualified urologists, maybe specializing in ED, or certified sex therapists. Organizations mentioned in the source, like the American Urological Association or AAC, can also be good resources.
Thank you for joining us for this important deep dive.